Good morning to all. Thanks, Dr. Ropsy, for the warm introduction. It's a pleasure to be here with you, sharing love in Valentine's Day. And it's my pleasure to go over this topic, which is something that very commonly comes up in my practice and probably in yours too. So on the next 15 minutes or so, those are the main topics that we're going to cover. First of all, I'd like to take a step back before talking about CT or MRI and come to the discussion of, does my patient actually need an imaging study? That may be the most important question, and Dr. Ropsky has made some comments about it. We're going to try to give a little bit more information. So if we do decide that our patient needs an imaging study, what are the main pros and cons of CT versus MRI? We're not going to go into all the nitty-gritty details, but I just want to put some of the most important differences that should guide your decisions when selecting the right skin for a patient. Finally, what should I specifically order when a patient comes to me with a main complaint of headache or back pain? Throughout the presentation, I'm going to make constant reference to the American College of Radiology Appropriateness Criteria, which are a series of guidelines for best practices that are freely available online, and I think most speakers will be talking about it today. So why is this a problem at all? Why are we talking about this? Dr. Ropsky has shown some curves, and those are similar to demonstrate that the rate of growth of physician services in the United States over the last decades is just impressive. And if we look closer, we can see that imaging itself has grown at a disproportional rate to all other services when compared. Most problematically, in many situations, this has happened with very little data backing that imaging usage is actually associated with improved patient outcomes. That is not, of course, not true for most of the diseases that we treat, but there are certainly some specific situations in which abuse happens and lots of resources are wasted. This has raised a lot of important concerns for stakeholders, from insurance plans, Medicare, several government organs, and of course, us, taxpayers. So to prevent widespread cuts and unjustified conditions to practice medicine, the American Board of Internal Medicine Foundation, the American College of Radiology, and Consumer Reports, with help with other medical associations, have sponsored the Choosing Wisely initiative. The main goal of Choosing Wisely is to provide evidence-based recommendations for patients and physicians to make right decisions when choosing a diagnostic study or a treatment plan. The medical institutions from Choosing Wisely came up with an extensive list of the most commonly overused and abused imaging studies. And we can see that imaging for headaches in patients without risk factors or structural problems, and imaging in patients with low back pain in the absence of red flags are right in that list. So how prevalent is this problem? How big is this issue? It's very, very common, and that's your daily life, as you know well. Headaches have been cited as the most common type of complaint overall, bringing patients to physician offices, accounting for more than 10 million visits annually. In addition, it's a major cause of disability, causing diminished quality of life and costing billions of dollars yearly due to missed workdays. So it's a big healthcare issue without an easy answer for approach. Imaging for headache is standard of practice, and it's commonly done throughout both outpatient and inpatient scenarios. But it has been found that isolated headaches without risk factors and without trauma history has actually a very, very low yield for a positive diagnosis, which is estimated in less than 0.4. So if you consider an average reimbursement of $400 for CT and $900 for an MRI, the cost for detecting a single significant treatable lesion can be up to $100,000 and more than $200,000 for MRI. So how does one decide which patients need to be imaged? How does one differentiate primary from secondary headaches? Unfortunately, the answer is not very straightforward because we don't have any solid data coming from randomized controlled studies showing the right patient populations in a prospective setting. All we have are retrospective data, and although it's not ideal, it has substantially shown two main points. First of all, patients with migraine type of symptoms in a normal neurological exam have an extremely very low yield for a positive study. So these patients probably don't need any imaging at all, unless something comes up during their treatment and their management. So the higher yield for diagnostic imaging for patients with headache can only really be obtained if we observe any danger signs. The list of danger signs is pretty long, but this is something that you're very well aware of. That's part of your routine clinical evaluation when seeing those patients, and those are some of the most common things we have to be looking out for. Patients with sudden onset of headaches or severe persistent headaches that reaches maximum intensity within a few seconds, the presence of focal neurological symptoms, descriptions of the first or worst headache of their lives, which is definitely different from a pre-existing pattern, new headaches in patients under the age of 5 or over the age of 50, where the prevalence of pathology is much higher, unexplained fever or changing mental status, and headaches in pregnancy, postpartum, cancer, and HIV patients. Back pain, as Dr. Rofsky mentioned, may be even a greater problem. It is cited as the most common symptom-related reason for physician visits, so it's extremely common, with a prevalence in about 1 in every 4 adults in general populations. It's a leading cause of disability in patients under 45, and the costs associated with management of patients with back pain exceed the rate of $100 billion per year. Again, a huge problem. Fortunately, the American College of Physicians have provided us with very specific and clear guidelines when imaging patients with back pain. After review of a metadata containing several randomized trials looking at the cost effectiveness of imaging in patients with back pain, the bottom line of their practice guidelines is that imaging is not indicated in most patients with no specific back pain. And that is substantiated by most guidelines provided by physician organizations such as the ACR. There are only 3 main groups of patients that actually need to be imaged in the setting of back pain. Patients at risk for severe or systemic disease, like cancer, infection, or others. Patients with urgent findings in which there is suspicion for a spinal deformity or compression of the neurostructures, and those are some of the symptomatology that these patients may present. And patients with persistent radiculopathy who are candidates for surgery or some percutaneous intervention. If we do decide that our patient needs an imaging study, how should I proceed? There are several differences that are inherent for CT and MRI, but what really drives clinical decisions in most cases is diagnostic performance. We know that CT is a modality which is excellent for bony detail and sensitivity for acute hemorrhage, making it an ideal study for emergency patients. But it only has moderate narrow and soft tissue contrast, so it really lacks significant specificity and sensitivity in many other clinical situations other than trauma or life-threatening immediate situations. MRI, on the other hand, has excellent narrow soft tissue contrast with great flexibility for most diagnoses. It has poor bony detail and only moderate sensitivity for acute hemorrhage. So MRI actually is the standard and the most efficient imaging study for most of the neurological applications other than trauma and some specific life-threatening situations in the ER. So sometimes ordering CT before an MRI actually doesn't save costs, as Dr. Rofsky has mentioned. There are some other differences, like body effects, which are negligible in MRI and involve radiation exposure on CT. Additional risk of contrast injections, such as contrast-induced nephropathy in patients with CT, and the effects of nephrogenic systemic fibrosis in patients with end-stage renal dysfunctions that receive gadolinium in MRI. And time to scan may be a very important thing to consider because uncooperative patients are much more likely to tolerate the very fast scanning times of CT in comparison to laying down without moving in an MRI magnet for extended periods of time. Unfortunately, there's no single answer on what to order for a single symptom like headache or back pain. To relieve some of that confusion and complexity, the American College of Radiology has been publishing appropriateness criteria since 1993, which are practice guidelines based on the most supportive and substantial evidence that includes documents for diagnostic imaging selection, radiotherapy protocols, and image-guided procedures. The most current version of the ACR document has over 110 topics with short of 1,000 variants for imaging. So we see that for neurological imaging, we have approximately 20 topics, and headache and low back pain are two of them. Each document contains a summary of literature review to indicate where the recommendations are coming from, and a rating scale in which 1, 2, 3 is used for situations in which a study is very rarely and usually not appropriate, 4, 5, 6 in situations when it may be appropriate depending on clinical judgment, and 7, 8, and 9 for studies which are the standard of care and usually appropriate. So that's an example for appropriateness criteria for patients with headaches, including variant 1, which by far is the most common situation for patients presenting with headache. We can see that no study receives high grades on this setting, and image is usually considered not appropriate, especially if patients have classical migraine type of symptoms and no neurological findings on the physical exam. If by clinical judgment any study is necessary, MRI is usually recommended, and the selection of contrast will depend on the underlying clinical hypothesis. SecondVariety is very different and includes patients with subacute or chronic headaches with a new feature or a neurological deficit. So we can see that MRI without and with contrast receives the higher marks because of its, again, excellent diagnostic performance and true ability to the best of what we have today, exclude any significant intracranial abnormality. These patients are at more significant risk for pathology, so contrast is usually recommended to exclude infectious or neoplastic disorders mostly. CT should only be used in patients who have contraindications or in situations of limited availability of MR. Variant 3 are patients that present with a sudden onset of severe headache, which sometimes is labeled the worst headache of their lives. Those patients typically are seen on the ER, and they should definitely be managed with a CT head without contrast, which is a very fast and efficient study to rule out any life-threatening immediate complications. The use of CTA is commonly performed in patients who have strong suspicions for an aneurysm. MRI is more efficient as a troubleshooting technique or when there's persistent clinical suspicion with a negative CT. There's actually a long list of variants for patients presenting with headache. I won't be able to cover them all, but the American College of Radiology has very specific documents, and most of your patients will fill into one of these situations. First variant of back pain is the overwhelming majority of patients, and we can see that in patients with uncomplicated acute low back pain or radiculopathy in a non-surgical presentation and without red flags, don't need any imaging at all. That's the single best opportunity that we have for saving healthcare-related costs when it comes to imaging in neuroradiology. Variant 2 refers to patients that are at a more significant risk for a vertebral deformity or compression of neurostructures, having one of those scenarios such as osteoporosis, a progressive or focal deficit, a prolonged symptom duration, or age over 70. Given the increased risk, MRI is usually recommended in these patients, and doing CT first is usually a waste of time and cost concerns. Third variant for low back pain refers to patients with radiculopathy who typically have failed medical management and are true candidates for surgery or intervention. For anatomic evaluation, MRI is also the superior study here, and ordering CT is sometimes done by the surgeon if there's any concern for the bone anatomy, but most commonly not necessary. Lastly, for patients with suspicion of systemic disease such as cancer, infection, or which are immunosuppressed, MRI should be requested with and without contrast due to our ability to better see epidural and intrathecal disease, which may make big differences in patient management. MRI without contrast to be done for patients with contraindications, and CT usually has a much poorer performance. So I'd like to wrap up with the main message that choosing wisely is very important in our practice, and that given this disproportionate growth of imaging services, we're all facing the risk of practicing medicine in an environment where severe restrictions and widespread cuts will limit our ability to perform good care. Headaches and low back pain are the main targets for cost reduction in neuroimaging, and please refer to the ACR criteria whenever you have a patient in doubt of what's the right scan to order. If you have any questions, just give us a call. We have a radiology consultation service, and that's the phone number which is also present throughout this presentation. We'll be happy to assist you with any doubts. Thank you.